Good afternoon, interest. Thank you very much for this generous and highly quantitative introduction, which I like being an epidemiologist. So I want to take you through TB case finding, the role of new technologies, and I have no conflict of interest to declare. Now you're all aware that the molecular revolution has basically also revolutionized tuberculosis diagnosis. There are currently 3 low complexity automated tests, like the Gene Expert, but also a couple of others that are WHO recommended, and there are also a number of high throughput systems now recommended. But that hasn't really completely solved the problem. What you see here is the estimate of the WHO of the total number of tuberculosis cases, that is the incidence in the world, and that's the green line on top. And on the bottom in this black line, you see the number that is notified it. And there is this gap, this diagnostic gap. Now, why is there a gap? Obviously, these are, to some extent, people who were diagnosed but never notified. There will be people who self-healed before diagnosis, but probably the large proportion of that is people who were not diagnosed and remain with tuberculosis. And that, to me, is due to 3 key diagnostic problems. The first one being that there are people who can't produce sputum, and obviously, in the TB world, we've always been very fond of our old sputum as the main sample. But there are also people who, while they go to a clinic with symptoms that may be due to TB, basically they cannot access TB tests. And then finally, there are people who have TB but who are not sick. And these call for a different kind of diagnostic intervention. So I'll start on the first with non-sputum-based diagnostics. Then for the second, it's triaging. And for the third, it's screening. I really like to distinguish between those 2 concepts. I'll tell you later why. I'm not sure that everyone is aware of that. So let me start with the non-sputum-based diagnostics. So the WHO already came out with a target product profile in 2014 for these kind of tests. And the idea is that they would diagnose pulmonary TB in people who do not expectorate and diagnose extrapulmonary TB. And these TPPs had desired characteristics. These should be tests that could be used at the health post level without a lab, yield same-day diagnosis with a minimum sensitivity of 80% and a minimum specificity high of 98%. And there are a couple of samples other than sputum that have now been investigated. I just list a few of there, but I'm only going to talk about the top 3. So the first is urine. You're probably all aware of urinary LAM. So that's basically an antigen test on urine that's done on a dipstick. That has been around for quite a while. This is data from the WHO from a systematic review. And it shows that, as you can see here, this is on people living with HIV, you can see that the sensitivity is definitely not high, but the specificity is sort of reasonable. But the sensitivity becomes better in inpatients and people with CD4 counts below 100. But obviously, there is still need for an improvement of these test characteristics. What we've seen recently is this new assay, the Fuji Silva LAMP, LAM assay, and that actually performed, as you can see in these forest plots, better than the Alere lateral flow test. But unfortunately, there appear to be lot differences, lot variation, and that precluded WHO recommendation. Now, there are now a number of studies ongoing with follow-ons, some that include sort of tabletop spinning of samples, and I think they all look quite promising, but I can't share anything on that yet. Others have looked at molecular testing on urine, so Gene Expert on urine, and this is showing you some data from Gene Expert Ultra on urine. Actually has poor sensitivity, so this is again in people living with HIV, in this case with advanced HIV disease. But as you can see from these 2 Venn diagrams, the left one in a multi-country study, the right one in hospitalized patients in Brazil, you can see that there is at least some additionality over and above all the other diagnostics that are then being employed. I think more interesting or more promising is MTB detection in stool. There's had quite some attention, especially in children, because that's relatively easy to get stool out of a child. Shit happens, as my colleague who's sitting over there had in her PhD thesis at the time. But you see here from the systematic review that actually the sensitivity is quite variable. The specificity, however, as you see on the right-hand side, is pretty high. And now actually people have been trying this, and this has been work by George Kasuli of the Stool for TB project that we're involved in, actually been trying this on adults with HIV. And as you can see from the Venn diagram on the very right-hand side, Stool ultra actually gives additionality, so there's additional yield in diagnosis of tuberculosis in this patient population. And as you can see on the left-hand side, and it's the blue bars that you need to look at, actually in those that have CD4 counts below 200, the yield, diagnostic yield of stool ultra was better than ultra on sputum, was better than urinary lamb or sputum culture. Another sample type that has gained a lot of interest recently is detection on oral swabs. This is also from a systematic review, and what you see here is that basically sensitivity and specificity are all over the place, and there are reasons for that. Because the accuracy depends on a whole bunch of things. Tongue swabbing is apparently better than swabbing anywhere else in the oral cavity. It depends on the number of swabs that are being done, the duration of the swabbing. It depends on the type of swab that's being used. It depends on the testing protocol. And obviously, those that have a higher bacterial load have a higher yield also on swabbing. But it's probably an option for active case finding. I will say more about it at the very end. For example, in household context, one option might be pooled swab testing, for example, on GeneXpert, but another one might be tabletop molecular swab assays that were actually developed during the COVID-19 pandemic because people needed them. And these have been now turned into tests for swabs for tuberculosis, and they look quite promising. Now, I move on to triaging. Now, triaging is really meant for symptomatic people who present at health facilities, and the idea is that by that you can decentralize testing. Because very often, for example, for GeneXpert, people either need to go to a clinic, or their sputum sample needs to be transported there, or to allow more people to be tested. So if there's a lot of people who are coughing in a waiting room, you can basically better sort of identify whom you should test with your molecular test. And actually that graph shows how that works. So there's also a WHO TPP for that. Desired characteristics are it should work in pulmonary and extrapulmonary TB, should be employable at the community level, should give a rapid result, allow immediate referral, and very important, should be inexpensive. So the minimum sensitivity should be 90%. You don't want to miss people with tuberculosis, but the minimum specificity doesn't have to be that high. And that is because the specificity here is really a trade-off with cost. And if you have questions about it, I can explain that to you later. Now, there's a couple of triaging approaches that have been tried. Here you see one from an IPD meta-analysis that was published already 2.5 years ago, where they looked for 22 studies in people living with HIV. They looked at these different options. The first was the WHO 4-symptom screen, so that is cough of any duration, fever, night sweats, or weight loss. And then you see C-reactive protein, on the bottom you see chest X-ray, and as you can see on the right-hand side on the graph, actually CRP is actually performing better than the symptom screen, and as you can see from the table, it also actually performs better than chest X-ray, independent of the cutoff you would use. And this is interesting because CRP can be tested by point-of-care testing on finger prick blood, and there is actually equipment out there that can be used right on the tabletop. These same researchers also looked at whether it would actually help if you would add clinical information to see whether that would increase the performance. And here you see they had this model. They included age, BMI, CD4, and cough on top of CRP. And you can see there that on the bottom you see the C statistic of 0.81. That's basically your area under the curve. So it looks pretty good. But this is if they only included CRP. It's exactly the same. So it means that basically CRP in itself is a pretty good triage test. You don't need other information, at least from this data. So are there alternative or additional point-of-care tests? So this is work that's now being done with a PhD student of mine from Uganda, Kevin Komakech, and he has just submitted this systematic review, it's just been accepted, where he looked at CRP, the 3-gene host response cartridge of experts, monocyte-lymphocyte ratio, and hemoglobin, and on the bottom you see the sensitivity and specificity. You see on top C-reactive protein performs pretty well, but actually this host response cartridge performs better. The issue here, so this is based on an RNA sequencing signature, and that's great, but the problem here is that it is the same kind of cartridge on the same equipment that you would use for expert testing. So the question is there any point in using it as a triage test? And other alternatives, and again about these alternatives, is I've just completed a head-to-head comparison looking of really point of care, CRP, IP10 on lateral flow assay, monocyte lymphocyte ratio and hemoglobin in an adult patient population. About 1/3 was HIV positive in Kampala, Uganda. And what you can see from the graph here is that the CRP, that's the blue line, performs best, but IP10 and monocyte lymphocyte ratio are pretty close. And interestingly, the performance varies by HIV status. So if you look on the left by sensitivity, you can see that for here, the monocyte lymphocyte ratio, which thus far had mainly been studied in people with HIV, actually has a sensitivity that is similar to CRP. And if you look at the right-hand side, that hemoglobin, also mainly studied in people with HIV, has a similar specificity as that of CRP. So there is promise there. But of course, we would, in the end, want something that is non-invasive. We don't want to finger prick or other blood draws. So there's a couple of interesting developments. On the left, you see AI-based smartphone cough sound classifier. So that's based on the principle that different conditions in the lungs produce different cough sounds. So we, at the human ear, can't distinguish them, but these microphones can, and AI equipment can. And there's a couple of projects now. We actually saw one project yesterday in the TB meeting, and there's another one that we are involved in that we're actually now trying this out, training the algorithm and evaluating them. And yet another very interesting one is on the right-hand side, which is point-of-care ultrasound for pulmonary TB. That seems pretty promising as well. Now, finally, on screening, this is about the issue that people with TB actually may not be sick. And in the HIV world, people were familiar with this. I mean, already 20 years ago, this was an observation that in TB screening of people with HIV before the start of antiretroviral treatment, or IPT, that there were actually quite a few who had no symptoms or no typical symptoms. And we've now learned that also in the sort of the general population. What you see on the right-hand side is from a systematic review of TB prevalence surveys, where basically a large number of people, thousands of people, have chest X-rays and ask for symptoms. And as you can see there, about 50% there are subclinical, which now the WHO calls asymptomatic. That's why both terms are there. But it depends also on how that is calculated and its definition. So this is work by my postdoc, Logan Stuck, who did an IPD meta-analysis of 12 of those prevalence surveys. And he standardized all the criteria across those prevalence surveys because they were quite different, and used 3 different definitions for asymptomatic. And here you should look at the very right-hand column, basically for not having cough for more than 2 weeks. The proportion in those surveys after adjustment for incomplete sensitivity and a few other things was actually more than 80%. And not having cough of any duration was more than 60%. And on a subset of 4 surveys for which he had all that data, more than 25% had no symptoms at all. And interestingly here, and that's the blue part of those bars, about 20% of those who did not have prolonged cough actually had smear-positive sputum, which means they would be highly infectious. And people have been looking at that through modeling studies. For example, this comes from modeling of a combination of data from children and data from these prevalence survey, for these prevalence survey, and that actually suggests that 2/3 of the global transmission of TB could be due to asymptomatic tuberculosis. And the WHO, basically already in 2021, said, okay, in addition to people with HIV and household contacts and subpopulations with specific risk factors for TB, we should also recommend systematic screening in any population where the TB prevalence is above 0.5%. And that basically brings us to old-fashioned chest X-ray screening. This was the flavor of the day in the 1950s and 1960s in the United States and Europe and so on. And until recently, people thought, well, this is not something that we can do in low and middle-income countries. But then came the revolution in chest X-ray screening, basically for 2 things: the development of portable and even ultra-portable equipment and AI reading. And what you see on the left-hand side is what a chest X-ray nowadays looks like. It's like a big camera, just slightly bigger than your Probably not even bigger than your iPhone 13. So this is what it looks like. Very easy to do and not very expensive. And on the right-hand side, what has been developed is this system by which you actually have AI, artificial intelligence, reading of a chest X-ray, trained on thousands and thousands of chest X-ray, that actually provide a score of probability that that person has a chest X-ray that is consistent with tuberculosis. And the great thing of that is that you don't need radiologists or pulmonologists anymore. It's not that we want these people to lose their job, but there are so few of them in low-income countries. So, and there's now several CAT, that's what I called CAT, computer-assisted detection. Several of those CAT systems are available. This is just showing you for 3 of those CAT systems in a study by Find that shows that on almost 3,000 X-rays, that show that these CAT systems perform more or less the same if you compare them to radiologists or pulmonologists reading here with area under the curves of way above 80%. Now, the next question is, it's great that we have that, but can we make it feasible and affordable? What you see on the left-hand side is that there can be quite a bit of geographic variation in the yield of chest X-ray screening. There's a lot of chest X-ray screening programs now going on, especially with this new software and this new equipment. And this is showing it for Karachi in Pakistan. You see here, so the red dots, very high levels, and the low dots, very low levels of TB cases that are found in this chest X-ray screening. So what people are now thinking is, can we actually predict where we should go with our active case finding to get to optimize the number of cases that we find? And this is now also put in AI models linked to geographic information systems. What I show you on the bottom there is a very recent paper from Nigeria, where this is already being done in Nigeria. This is basically predicting where they would find most cases. This is in Lagos. Finally, are there alternatives to chest X-ray screening? And it brings me actually back to the issue of sensitivity and specificity. This was a very interesting paper from the modeling group of Hopkins. And what they showed here, this is a transmission model for five Asian countries. They actually showed that smear-negative asymptomatic TB, which is the dark brown columns on the lower columns, contributes around half of all TB in the community, but it often resolves spontaneously and it's less infectious and thereby contributed only 10 to 15% of all transmission on the right-hand side. So basically, should we, from a TB elimination perspective, worry at all about those smear negatives? Basically, old Carl's T-blow. And this is work that we've been doing with Jason Andrews at Stanford. It's a transmission model now for 3 Asian countries. We actually said, okay, now let's compare what would happen if we have a low complexity screening test. That's one with high sensitivity, like chest X-ray, moderate specificity. We all know that the specificity of chest X-ray is not perfect. But also by a moderate coverage, you can't basically, even with this equipment, you can't take it everywhere. And if we compare that with something that can be done very easily, for example, tongue swabbing, perhaps with pool testing in Gene Expert, that has a sensitivity. We know that is not really much better than smear. And if we would do that with a much higher coverage, then he showed on the top what you see is the impact that he showed on the 10-year tuberculosis mortality. And the light columns are actually this near POC screening test. And you see that if anything, it's better. You get a better, more reduction with that approach than that you would get with the chest X-ray kind of approach. And on the bottom, you see it's actually much cheaper. Those are the red bars. So it actually means that probably here you would like something that can be really rolled out, has sufficiently high specificity, but sensitivity may not be the most important thing that you should be looking for. So in conclusion, urine, stool and tongue swabs are potentially important samples for non-sputum-based TB testing. For TB case finding and health facilities triaging, C-reactive protein is the most sensitive test with reasonable specificity that is also feasible and affordable. So chest X-ray may not be feasible and affordable in all clinics, for example. Promising other biomarkers and non-invasive triaging approaches are in development. Much of TB that is prevalent in the community is without typical symptoms, calling for non-symptom-based active case finding. Portable equipment and computer-assisted detection is revolutionizing chest X-ray screening. GIS-based models may improve the feasibility and affordability of that screening, and TB screening with high coverage, moderately sensitive tests may have similar health benefits as chest X-ray, but at lower cost. And with that, I would like to acknowledge the people I've mentioned, and I thank you for your attention.